to try and raise the knowledge levels of people around long-term conditions. So what we try and provide for you is bang up-to-date information about a whole range of different conditions. And for me, the focus is mainly on long-term conditions. So I'm very interested in respiratory, cardiovascular, diabetes, those sorts of areas, and they sort of stray into chronic kidney disease and metabolic associated steatotic liver disease, which is the new kid on the block, really, I think, in terms of interest levels. So let me tell you a little bit about what I offer through Dovetail. From a respiratory point of view, I am the asthma lead for the Association of Respiratory Nurses. So it's always a pleasure to offer any up-to-date information around asthma, be that adult asthma or children and young people. I work in primary care, so I see people across the age spectrum with a whole range of different presentations of their asthma. And obviously in November 2024, we saw the publication of the latest asthma guidelines from BTS Sign NICE, which was a game changer, quite frankly. And the recommendations that came out from that particular publication have changed the way that we've managed asthma. So the focus these days is on combination therapies right from the word go. Combinations that include formoterol, because that's really important to make sure that people get symptom relief, but they're also getting management of their asthma through the inhaled corticosteroid. Very, very exciting times, to be honest. And it's a fast changing area because we have new licenses coming in that people need to be aware of. So I try and keep myself bang up to date so that I can help you keep bang up to date. From a COPD point of view, obviously my ARNS role is important, but I also sit on the executive committee of the Primary Care Respiratory Society. And I'm really interested in COPD, particularly actually because there's a new focus with COPD on cardiopulmonary risk. So whereas perhaps in the past we've tended to focus on exacerbations in COPD. We've focused on, how do we prevent those exacerbations, because we know every exacerbation increases the risk of a future exacerbation. That's been our focus. But recent research has shown that anybody with COPD who has an exacerbation of their COPD is much, much more likely to go on to have a cardiovascular event. So that's really troubling. And so what we need to do now is start thinking about COPD as a cardiopulmonary risk factor. And we know that there's a new Q-risk tool that may be available to use in the future called Q-risk 4. And Q-risk 4 contains extra risk factors, and COPD is one of those risk factors. So I think we really have to start thinking about what we do when we're seeing our COPD patients in terms of reducing their cardiopulmonary risk. So these days, there's quite a focus on the dual bronchodilators, the LABA-LAMA combinations, and actually thinking about identifying those patients who will benefit from moving to triple therapy, which we know is associated with a reduced risk of cardiopulmonary events. Very exciting times with that, really. So I think it feels like it's gone full circle with COPD, because we are going back to using inhaled corticosteroids in COPD in those patients where it's appropriate, of course. And, we started off doing that, and then we stopped doing that, and now we're back to doing that again. Other areas that I'm really interested in is things like chest clearance in people with COPD. So using devices to ensure that patients are able to clear their chests of sputum so that the drugs can actually get down there and do their job. So there's lots going on in those areas. I'd love to see an increased use of the devices, Aerobica and other devices that can really help people to clear their chests. Very exciting time in that respect as well. Um, Talking of things cardiovascular, I have a real interest in cardiovascular disease. So I am president-elect of the Primary Care Cardiovascular Society. And what I love about cardiovascular disease is the way it encompasses so many different areas. So you've got patients where you're assessing risk, you've got patients where you're addressing those risk factors, you've got, I shouldn't say patients, I should say people. You've got people who've had a previous cardiovascular event. So we're looking at secondary prevention. And I think all of those elements have really come to the fore with the new QOF guidelines. For those of you working in primary care, you will know that there is a huge focus now on reducing cardiovascular risk, particularly in secondary prevention cases. But, you know, we should be looking across the board at everyone and trying to reduce risk. Now, one of the main ways that we're going to reduce risk is actually through lifestyle. Really important to remember that. And there are some really interesting developments in that respect. I think we've stopped saying the same old that we've said for decades about the old, eat less, move more thing. Not to say that that isn't necessarily inappropriate to say, but I would say eat right and move more would probably be the thing. So we've got some really good new ideas about lifestyle management. We've got ideas around, time limited eating, intermittent fasting. Do we go low carb? Does the fat not matter anymore? All of these elements coming in here that I think are changing our perspective on what advice we should give about lifestyle management. And even with the exercise side of things, we realize now that different types of exercise are important, and also that even in people in their 60s and beyond, ongoing exercise is really important. So I think, when we combine the dietary approach with the physical activity, then we can help people reduce their risk of a cardiovascular event, whether they're primary or secondary prevention. And of course, we also need to bring in advice around alcohol and advice on smoking. And of course, that's changed as well, because in February this year, 2025, we actually saw the publication of the new guidelines from NICE on smoking cessation. And they highlighted a new therapy that's available for smoking cessation. I've been using it in practice with my patients, and they're doing really, really well on it. That's cytosine. They also highlighted varenicline and dual nicotine replacement therapy. The debate around vaping and electronic cigarettes continues. But, I think it's important for any of us who are working in long-term conditions or anything else in healthcare, quite frankly, that we know about smoking cessation, that we know what's available, because a lot of patients will tell you, I'm going to apologise for constantly saying patients, drives me up the wall, so I don't know why I keep doing it, but people who want to quit smoking, they may come to you and they may ask you for advice about what's available, and they may tell you that they've tried everything, but it's highly likely that they haven't tried everything, because cytosine is a new therapy. Varenicline's been off the table for quite a while, is back available again. So we really need to be clued up as to what's available, so we can support people to make the right choices for them, of course. And then we've got obviously the risk factors for cardiovascular disease that need pharmacological interventions as well as lifestyle interventions. So hypertension is something that I love to talk about. So hypertension management, the difference between the UK and Europe. Goodness me, it's very exciting, because Europe, as usual, goes in harder than the UK. You might want to debate why that might be. But Europe goes in harder with tighter targets for hypertension management for different cutoffs in terms of what they consider to be a normal blood pressure versus a raised blood pressure that isn't yet hypertension. And then when you get into actual hypertension, and Europe again goes in hard, not just with the targets, but also with the medication. So they go in with 2 drugs to start off with. Well, we know that most people with hypertension will need 2, if not 3 drugs to get them to target. And that's our lazy UK targets. So why don't we just go in with 2 drugs at the start? Very interesting. So these debates are really worth considering, because what you're really thinking about, quite frankly, is the difference between the evidence base for getting blood pressure down. And you can look at the KDIGO guidelines as well, the kidney guidelines, which also have tighter targets than we have in the UK. So you look at the evidence base versus what often drives us in the UK, which is, of course, money. So NICE is charged with thinking about the economics of what we do. Could it be that that's what makes us a little bit more behind the curve when it comes to trying to target blood pressure? I don't know. You decide. So that's our hypertension. We are also linking that into chronic kidney disease, because there's a huge issue around chronic kidney disease, underdiagnosis, people not being aware. Blood pressure obviously plays a big part in the management of chronic kidney disease, but also we need to be looking at other elements as well, such as lipid management, the use of SGLT2 inhibitors, the use of MRA, so things like spironolactone, eplerenone, do they play a part? Actually, that's probably more your heart failure, but a lot of your patients will have heart failure and chronic kidney disease. So we have to think about where these things all join up together. So your chronic kidney disease patient, it's going to be, let's get the blood pressure down, let's treat them, hypertension or not, with ACE inhibitors or angiotensin receptor blockers. Let's get the SGLT2 inhibitors in there. Let's make sure that we're doing everything that we can. Actually, the MRA that you use in CKD is slightly different from what you would use in heart failure. CKD in people with diabetes, we'd use finerenone, which has got a lot of information coming out about its use in heart failure. You see how these things overlap? Fascinating. Of course, SGLT2s for both of those conditions as well. So this, I used to call it knitting with NICE, where we get all of these different conditions and they're all overlapping and they're all interlinking. It's fascinating. Sometimes people say to me, how come you do all of these different conditions? How come you've got an interest in all of these different conditions? Well, actually, it's because they all interlink. It's because, to my mind, you can't be dealing with COPD without thinking about cardiovascular disease. You can't be doing heart failure without thinking about their kidneys. And that's a really good example of, pharmacologically in heart failure, we're looking at using spironolactone and eplerenone. In diabetic kidney disease, it would be finerenone. They're all MRAs. You need to know your stuff. And then, joining some of the courses, some of the sessions that we put on with Dovetail will be the way that, as I always say, you find out what you don't already know, because you don't know what you know until you know it. And you don't know what you don't know until you know it either. So sometimes it's really worth thinking about joining a session that isn't perhaps your special area of interest, because chances are there's an overlap somewhere. So as I said, with COPD and cardiovascular, we're seeing a huge overlap between those two now. And who knew that cardiologists would be speaking at respiratory conferences and respiratory clinicians would be speaking at cardiovascular conference? It's happening. It's already happening out there with the organizations that I work with. So sometimes, dip your toe into the water of something a little bit different. So lipids, one of my favorite topics. I love lipids. They are really coming front and center at the moment, partly because we've got a lot of new medications on the horizon, not necessarily available now, but coming our way. And that's really driving our thoughts around how we measure lipids. So if you look at our lipid profile, you've got total cholesterol, you've got HDL cholesterol, you've got LDL cholesterol, and then you've got your triglycerides. And increasingly at the moment, we're hearing more about lipoprotein little a, coming to a laboratory near you soon. It might already be available. So when I first started learning about lipoprotein little a, one of the things I needed to do was find out, did my lab actually provide this test? And I was delighted to find out that they do, not always the case. But lipoprotein little a is something that is established, if you like, in babyhood, very early in life, and it stays pretty much constant throughout your life. But the higher your lipoprotein little a, the higher your risk of cardiovascular disease. So we have treatments coming available soon for lipoprotein little a. And that's why we might want to start measuring them. But even before those treatments are available, if you measure lipoprotein little a and it's raised, you know that that individual, irrespective of the rest of their lipid profile, that individual is high risk for cardiovascular disease. So that means that we really need to think about reducing other cardiovascular risk factors before these other treatments are available. So obviously one of the key things that we should be doing, anyone who's heard any of my sessions will know I'm passionate about statins. I believe that they really are something that most people should consider being on. So when we look at our lipid profile, we have to remember that the numbers are important, obviously, because we want to get those numbers down. But actually what we're looking at is risk. So when we're thinking about cardiovascular risk, we'll do a cardiovascular risk assessment using Q-risk. And then if the risk is 10% or more, then statins are indicated. Going back to CKD, I mentioned statins there routinely because anyone with CKD should be on a statin. Irrespective of their numbers, they need to be on a statin because their cardiovascular risk is so high. You see again how they all link up. These are not separate subjects. They are all beautifully linked together. But what we're hearing about more as well is in secondary prevention, LDL levels we need to know because we can bring in inclisiran, for example, based on an LDL level. We can bring in Vazkepa in anybody who's had a previous event whose triglycerides are raised. So we need to know all of these numbers because they're indications for treating. And I think this is really important that we think about what we're measuring and why we're measuring them. I mentioned metabolic liver disease. That is a cardiovascular risk factor. So many people with metabolic liver disease will need a statin and other approaches to reduce their cardiovascular risk. Again, new treatments coming our way in the future. Watch this space. And I'll probably finish off on a little bit around diabetes. Oh, I love diabetes. I love diabetes because diabetes is a cardiovascular disease. And I've already said I love cardiovascular disease because there's so many elements to managing it. So diabetes, every session I do with diabetes, I try to simplify it. So I try and get across the key messages about consider the kidneys, consider cardiovascular risk, think about the sugar levels, sure, but actually blood pressure and lipids are desperately important too if we're going to reduce future risk. And we also need to think about the plethora of drugs that are available to us. Maybe slightly get our blinkers on and focus on the ones that we know have the greatest benefits. So at the moment, they are the SGLT2 inhibitors and the GLP-1s or the GLP-1 GIP combinations. These are the drugs that are changing the lives of people with diabetes by not just supporting glycemic control, but actually helping with blood pressure, helping with cardiorenal protection. So important in people with diabetes. and also helping with weight loss. And we know that we are about to implement the NICE guidelines nationally for weight management. Really important that we think about that. Very, very exciting times in diabetes. And again, more therapies on the way. So I think we should really be focusing in on diabetes as a cardiovascular risk disease, and doing everything that we can to reduce risk. And I think international guidelines, again, sorry to say, lead the way. You know, you need to look at the American Diabetes Association with the European Association for the Study of Diabetes to see what their recommendations are. At the moment, I have to say, we are waiting for the new guidance from NICE on diabetes. It's been delayed, and it's interesting to consider why that might be. So by the time you see this, maybe it will be out. But honestly, I go to the ADA EASD guidance for my recommendations, the same as I go to the European Society of Cardiology for anything around cardiovascular disease and so on. I could go on. I could talk about atrial fibrillation. I could talk about medical legal stuff, particular interest of mine since I did my MA in medical ethics and law. It's a really interesting area because I think we're challenged at the moment with people who have a focus on the cost of medications and will try and pressurize us into not prescribing drugs that cost a little bit more. I've heard horror stories about some areas of the country where they're being encouraged to prescribe sulfonylureas again in diabetes, and also, you know, some real restrictions on prescribing drugs like inclisiran. And, you know, I think from a medical legal point of view, we have to think about what is ethically right, what is medical legally right, and do the right thing by our patients. So that's something else that I cover. Anyway, I'm going to leave it there because hopefully what you'll want to do now is go off and explore Dovetail's courses, see what's available, sign up for them. And maybe I'll see you there in one of my sessions in the future. I very much hope so. But it's been lovely having this opportunity to talk to you. And I hope that's given you a little bit of insight into what's going on in the world of long-term conditions. My name is Beverley Bostock, and I look forward to speaking to you soon.